Yeah, so interestingly enough, I didn't know much about this CR knee stuff a few years ago. So this is really for the PS surgeon that wants a little fast course on how to do a CR knee. These are my disclosures; they're not relevant. But this is a more important disclosure. Uh, I'm a trained PS surgeon. That is my bias. And if my father saw me giving this lecture, I'd be in a lot of trouble. So what happened? I became interested in non-cemented fixation. And the system that I use for non-cemented fixation is CR. So I had to teach myself because nobody at HSS knew how to do a CR knee. And so basically, right now, in certain cases, I do everything my father and John Insall taught us not to do. I don't cement. I use a CR knee. It's a rotating platform. I don't resurface the patella. And I liked it so much, I started doing cemented CR knees in older folks too. And it just, as I was doing them more and more, I started to realize that 99% of the time, the problem is a tight PCL, which manifests as the bearing lifts off in deep flexion. You have anterior subluxation of the tibia. The knee simply won't reduce. So it's not a sizing issue of the components. The sizing of the components, you just want to match to the shape of the bone. But then you got to balance the knee. So the keys to success with a CR knee is starts with the tibia. I think not enough surgeons cut enough tibia often enough. And you put yourself in a hole by undercutting your tibia. A degree or two of varus is okay, but you must have some posterior slope to match the patient's initial slope. I think measured resection in the CR knee works best, but I always check my gaps. And nowadays, we have these highly conforming deep dish designs, the ultra congruent designs. I think that's the way to go. And then you use the polo test that's been well described by the guys in Boston. And, you know, it stands for a pull out and lift off. So it shouldn't be so loose that you can pull out your trial tibia component, and it shouldn't be so tight that the trial lifts up. Look for anterior subluxation. Literally, the tibia won't fall underneath the femur. And if it doesn't fall underneath the femur, your tibia, your PCL is too tight. And if you're using these highly conforming deep dish designs, don't be afraid to recess or completely resect the PCL. You sort of start in the top of the notch and you work your way around, and you'll see the knee just self-reduce. And then you know your knee's balanced. Use a polo test again, double check, and then make your final stability checks with the extensor mechanism reduced. So it works well despite all I was told. It can be a slightly faster operation because there's no box to prepare. There's certainly less peripatellar crepitation and clunk. Here's an example of that peripatellar crepitation in a PS knee that we still see 1% to 2% of the time. But you know, I still do many PS knees for large deformities and valgus knees and complex cases. I still use cement in the majority of cases, and I still resurface the patella in the majority of cases. And I still use a fixed bearing design in the majority of cases. But I think there is a role for CR knees, and I think the thing that I want to finally express to the PS surgeon, if you're going to do this, is the goal, in my opinion, is not equal flexion extension gaps. For a PS knee, my goal is to have a slightly tighter flexion gap. And I think that works much better in a PS knee. Whereas in the CR knee, I want a slightly looser gap, which allows me to release my PCL. I, of course, will tolerate equal gaps, but not the reverse. So I don't want a loose flexion gap in a PS knee, and I don't want a tight flexion gap in the CR knee. And if you follow those simple guidelines, you'll get good outcomes. Thank you very much.